This conference will now be recorded.
Assalamu alaikum wa rahmatullahi wa barakatuh. In the name of Allah, we'll start the third session revision for MRCOG Part2 for September 2020 exam. First guideline, we'll start with the guideline, the new guideline, operative vaginal delivery. Any guideline, when you are reading for the first time, you will get important informations, but when you are reading again and again, sure you will find more and more informations in the guideline. So we'll start with the operative vaginal delivery. It will take some time because it is a new guideline. So be careful when you are solving any questions regarding the labor scenario. There is operative vaginal delivery, just to follow the new guideline. We need one few to start. This is labor and delivery modules. We will cover today about 5 guidelines. Expected time 2.5 or 2.5 hours. So who wanted to share? I can share. Dr. Adila?
No, yes.
Okay. Okay. Yeah. Just a minute. Okay, Dr. Adila will start. You can see the screen.
Yes. Women give birth by assisted vaginal birth in UK. 10 and 15%, 5 to 7%, 20%, 3%. I think A.
A? You choose A?
Yes.
Okay. 10 and 15%.
10 and 15%.
Yes, so it's a correct information. So about 10 and 15 women will deliver in UK by operative vaginal delivery. It's about 1 every 8 women.
Yes. Okay, nulliparous women gives birth by vacuum or forceps in UK. A, 1 every 3, B, 1 every 4, C, 1 every 5, D, 1 every 6. It is A, 1 every 3.
So 1 every 3 women, nulliparous women, they will deliver by forceps. Okay, it's a correct answer also. So this is the second question correct. So about in UK, there is 10 and 15 women will give birth by assisted vaginal birth. It's about 1 every 8 women. And if we are comparing only the patient to not deliver at all before, so it's 1 every 3 women, they will deliver by vacuum or forceps. The rise in cesarean section birth in second stage of labor, this is reflect concern about loss of clinical skills. Because if I am a doctor and I have one patient fully dilated, I can't deliver, I can't apply ventouse, I can't apply forceps, I will deliver the patient cesarean. So increase the rate of cesarean section in the second stage reflect concern about loss of clinical skills. Sure, continuous support during labor, this is very important factor, will decrease the risk of assisted vaginal birth. Also, we should inform the woman who is in labor that increase with the epidural analgesia may increase the need of assisted vaginal birth, but it's less likely with the newer anesthetic technique. Inform woman administration of epidural analgesia either in latent phase compared to active phase don't increase the risk of assisted vaginal birth. So if the patient you are giving her epidural in latent or active, in both conditions this will not increase the assisted vaginal birth.
Okay. In second stage of labor, to reduce the need for assisted vaginal birth for patient not using epidural, A, lateral position or upright, B, dystotomy, C, supine. A, lateral position or upright position.
So if one patient, she is not in epidural, how we can decrease the assisted vaginal birth for her? So this will be lateral position or upright position. So what about if the patient, she is using epidural? If the patient is using epidural, lying down, lateral position, she will be lateral position but lying down. Rather than upright position, this is also will increase the rate of spontaneous vaginal delivery. So first, I will this patient taking epidural or not take epidural. If she is on epidural, so she will lying down, lateral position, so this will decrease operative vaginal delivery. If you have one patient nulliparous in labor, now she is fully, don't be hurry, just give her a chance. Don't even tell her don't push now, because some they are in hurry, just the patient fully and telling her pushing, patient will be exhausted, and also you will will increase the risk of rate of abortive vaginal delivery. Just delay. You can tell her you can take sometimes take rest, don't do pushing. So delay the pushing for 1 to 2 hours. This will also reduce the need for rotational and mid-pelvic assisted vaginal birth. Don't routinely, sometimes, especially in the delivery room when you have one patient pushing, so no need to give her more dose because we want her to push. This is occur in the daily practice, but this is will not any evidence that this is will decrease the incidence of assisted vaginal birth. This is just will increase the woman pain. So if you have one patient in epidural, continue epidural dose as same, because this is will not reduce the incidence of assisted vaginal birth. Insufficient evidence that use particular regional analgesia to reduce the incidence of assisted vaginal birth. Insufficient evidence to give routine oxytocin augmentation to reduce the incidence of assisted vaginal birth. So I will think I will give the patient symptom, maybe this is will decrease. No, there is insufficient evidence. If you are putting the routine symptoms, that this is also will reduce the incidence of assisted vaginal birth. Insufficient evidence recommend routine prophylactic manual rotation of the fetal malposition in the second stage to reduce the risk of assisted vaginal birth. So all this one, insufficient evidence that this will decrease the abortive vaginal birth. This is AMQ.
Okay. Barus women, 1.5 hours active second stage, cephalic plus 1 station, dark occipito anterior actively pushing, she not reactive epidural analgesia. Low forceps in the room, a perineal block in the room, low forceps in the room with use regional analgesia, mid forceps in the theater with use regional analgesia, ventouse in room with use of perineal block in the theater. Low forceps in the room, a perineal block in the room. A for 4.
So you choose A for 4. Okay, next.
Yes. By primary the women 2 hours fully dilated for 2 hours, cephalic 0, direct occipito anterior actively pushing, she not receive epidural analgesia. This will be mid forceps in the theater with use regional analgesia. C for 5.
So you are using C. Okay, so A and C. Next.
Gestational age 35 weeks, second stage, head +2 direct occipito anterior prolonged deceleration. The patient has idiopathic thrombocytopenia, count 70 times 10. This also will be forceps, low forceps in the room, perineal blockage in the room. A.
So A. Okay, so we'll check your answer if your answer correct or no. Just a minute. Okay, so A, C, and A. Usually in the exam, they will give 3 different answers. Be careful. In the exam, usually the 3 answers will be different, usually. But just here, just we need to practice about the new guideline. When you are going, can you mute yourself, mute your camera, doctor? Because this one will be posted in YouTube. So please, can you mute your camera? Okay. This can affect also the record. Please, if possible, you can. Okay, thank you. Try to mute your camera, still open. Okay. I don't. If anyone know him, just text him because I think he can't hear us. Okay. Okay. So now the next how we are going to do classification of assisted vaginal birth. So it's outlet, low, mid. So in the exam, how I'm going to do, how I will choose the suitable. Okay, now close. Okay, how now I will choose the suitable assisted vaginal birth. I will choose outlet, low, mid. How? Outlet, if he tell you that already you can see the fetal skull from outside without separating the labia. Already the head on the perineum, just you can see it without separating the labia, so this will be need outlet operative vaginal delivery. In low, it will be +2. So if the station +2, it will be low. Mid, if it is 0 or +1, it's clearly, very clearly in the new guideline. So don't confuse yourself. Outlet, if I see the head without separating the labia. Low, if it is +2 station. Mid, if it is 0 or +1. So I now choose which one I will outlet or low or mid. Next point, it can be rotational in the low, and it can be also non-rotational in low. In low and mid, there is rotational less than 45 degrees or more than 45 degrees. The next point, what is the analgesia I will give to this patient? She will need to, I will shift her to the theater, or she will be in the room. If you are going to do rotation, so the rotation will be in the low and mid. So rotation or mid, it will be in the theater. So the mid, all the mid, it will be, all the mid pelvic, it will be in the theater. It's easy. All the mid, the last one will be in the theater. Only the low, if you are going to do rotation. So you are going to do the rotation also in the theater. In outlet and low, you can use perineal block. You can do in the room, and you can use perineal block. But if you are going to give in the theater, you are going to give original block. But if this patient, for any reason, there is urgency to deliver here, and you don't want to wait for original block, you are going to have duodenal block for the patient. So again, outlet, I can see the head without separation. Low, either rotational or non-rotational. +2. Mid, it will be 0 or +1. Where is the theater? Which patient will be in the theater? Rotational, or mid? She will be in the theater. The first 2, you can do it in perineal block in the room, except if it is rotational. The last one, it should be in original block. Except you have urgency, you can do duodenal block. Okay. For birth, for which one we will need, if you are delivering the patient in the birth room, just verbal consent. Just you will need to inform the woman that you are going to deliver her and discuss with her, and if she is agree or not. Don't go in more details. You can check about the perineal block and the duodenal block just to know now the informations. Any extra informations we can post on the group. Just we need to know the first the rules. After this, we can do more details. Okay. The point, perineal, the first one, perineal block, the other one will be duodenal block. Okay, when you are going to do birth in the room, just verbal consent. Just you will talk to the mother, she tell you okay, so she give you already permission. This is we need verbal consent. But when you are going to shift the patient to the theater, either for mid-pelvic or rotational forceps, you need written consent. So you should concentrate well. This patient will deliver her where and which type of consent it will be needed. Indication of assisted vaginal birth, it will be fetal indication, maternal indication, or combined. Maybe there is two, maternal and fetal. Fetal, like suspected fetal compromise, TTG pathological, abnormal, fetal blood sampling, and sick meconium. So the sick meconium alone can be indication for operative vaginal delivery. Maternal, be concentrate in this point well, because you will, in much scenarios in the box, you will be confused. Just to follow the guideline. They tell if there is lack of progress of the patient delivery. So I will know this patient now, I should apply operative vaginal delivery or no. You will look this patient in a leprous or barren woman. So if she will deliver before, just make it like this: 3 and 2, 2 and 1, 3 and 2, 2 and 1. So 3 for the non-leprous woman, and 2. The longer duration if the patient using epidural. So if the patient using epidural and pass already 3 hours fully dilated, so this patient should deliver. Don't be confused regarding active or passive. Just they are putting it very clearly. Patient fully total active and passive 3 hours operative vaginal delivery. Without epidural 2 hours. For barren woman 2 hours, 2 hours with epidural, 1 hour without epidural. So in the exam, I will forget, no, 3 and 2, 2 and 1. Just to remember, okay? Patient exhausted, she can't push, patient distressed. Maternal indication for avoid valsalva, like cases of Nahia 3 and 4. Combined, maybe there is fetal distress or even there is another maternal indication. So just again, 3 and 2, 2 and 1 with regional analgesia, and it is the shorter time if she not receive epidural. Once you are not in hurry, because once they are seeing the patient fully dilated, they will ask her push, and this is will increase the patient risk for operative vaginal delivery. Maternal indication, it will be cardiac disease, hypertensive crisis, cerebral vascular disease or malformations, myasthenia gravis, spinal cord injury. Forceps and the vacuum extraction contraindicated before fully dilatation of the cervix, because there is all the information, I think in very old information, we can apply ventouse for 9 centimeter. No. Forceps and vacuum extraction are contraindicated before full dilatation. Why? Because they find that if applied before the full dilatation, this will lead to maternal trauma, and it can be severe and even lead to severe postpartum hemorrhage. You can apply forceps if you have breech and you want to deliver after coming ahead. You can use forceps. Vacuum extractor is contraindicated with face. It is biologic. I will put ventouse on the baby face, so I will extract his eyes. Okay, so vacuum extractor is contraindicated also with fetal bleeding disorders. For example, alloimmune thrombocytopenia, or the baby predisposing to fractures. This is relative. Be careful from the word. Relative contraindication. So he give you, it can be done. It can be done. Why? Because maybe the baby fetal head is deeply impacted. So if there is experience of obstetrician, see that this baby, it's better for him to deliver him vaginally, because also to deliver this baby and bring the head from the pelvis down during cesarean section, will be more risky for the baby. So if you find that can be more safer for him, so this is given a relative contraindication. So relative contraindication when if there is fetal blood bleeding disorder or this baby predisposing to fracture, but if there is experience of obstetrician involved and see that will be the safer option, it can be done. Low forceps accepted for assisted vaginal birth for the patient with bleeding. So if you have one baby with bleeding disorder, avoid vacuum extractor. Just apply forceps. Okay. If he give you the baby head deeply impacted in the pelvis, so he wanted to tell you that it will be difficult in the cesarean section. So Here you can apply forceps, but you can't apply ventouse. Okay, I'm talking too much today, I know, but I just, okay, Dr. Adila, sorry, you are here, okay?
Yes, I am here, but I can't see the next slide. Yes, I am here.
Sorry, okay. You are here?
Yes.
Okay.
I'm really sorry, Dr. Ghada, but the slide is not
not
clear.
moving is a screen or what? Screen not moving?
Yes, not moving. Yeah.
No. You can see the screen, the question, or no?
No, I can't see.
No.
I can't see the screen. I don't know why.
Dr. Adila, you can see.
No, it's not clear, Dr. Ghada. I'm really sorry. I don't know why. I don't know if my side or.
Hello?
Yes. Okay. Yeah. Now clear. Yes.
Yes, I can.
It is clear now, Dr. Ghada.
Can see the screen or no?
Yes, I can see.
You can see.
Yes. Which operative? Okay. Yeah. Now I can see. Yes. Which operative vaginal delivery carries additional? Okay. Which operative vaginal delivery carries additional risk for cervical spine injury? Low forceps, direct traction with ventouse, rotational birth with killing forceps, direct traction forceps.
Sound still not clear?
Sound not clear?
Now, yeah, yes, I can hear you now. Yes, I can hear you now.
Okay, which operative vaginal delivery carries additional risk for cervical spine injury? C, rotational birth with killing forceps.
Okay, so this is rotational birth with killing the forceps. This is carry additional risk for cervical injury. So this is correct answer. Okay, so this is non-rotational assisted vaginal birth. This will be low probability of failure, because if you are applying an instrument non-rotational and low, so the success rate will be higher, and also the procedure will be safer. But for rotational forceps, operative vaginal delivery, this is need experienced operators and the choice of the instrument. This will be according to the clinical circumstances and experience also of the doctor, and also patient also should be involved. Maybe the mother will refuse. The options for rotational, killing rotational forceps, manual rotation, followed by direct traction of forceps or vacuum, rotational vacuum extractor. You should discontinue the rotational forceps if it is not easily achieved with genital pressure. See, if you are applied rotational forceps and you see the head not coming easily, so it's better to stop the procedure. We will go to the next.
The advice is that vacuum birth should be completed within 3 to 4 contraction, 1 to 2 contraction, 5 to 6 contraction. A, 3 to 4 contraction.
So the vacuum birth should be completed within 3 to 4 contraction. Yes. Excellent. Just I will make the big picture sometimes because it will not appear in the slides, because I see when I'm moving the screen fast, it will not appear in the PDF. Okay. Here, I don't know if the screen appear now. Yes. Operator should be aware that there is no indication absolute. Just need a clinical judgment is required in all the situation. Blood-borne viral infection like HIV. If the mother she has blood-borne viral infection, this is not absolute contraindication to assisted vaginal birth. Be careful. Just you need to know the rules. because in the exam you will ask yourself, this is indicated or contraindicated. This is what will happen in the exam. I'm not sure from the information. Just to put rules. If you have rules, you can solve any question in the exam easily. But if the patient she has blood-borne viral infection by logic, you will not do difficult assisted vaginal birth. It should be something. The success rate should be high. You are sure that this baby will deliver easily. But if there is difficulty in the assisted vaginal birth, it's better to avoid, because maybe there will be abrasion for the baby, maybe there will be scalp trauma, and this can or also increase the risk of infection for the baby. And also you need to avoid fetal scalp electrode for the baby with blood-borne infection, viral infection, and also blood sample. So if you have one patient in the delivery room and you take a blood sample now from her, or you apply fetal scalp electrode, so you are thinking, I can apply ventouse, or this abrasion what I did in this baby I can't apply. No, you can apply. So vacuum extraction is not contraindicated following fetal blood sampling or application of fetal electrode.
Operators should be aware that there is a higher risk of subciliary hemorrhage and scalp trauma with vacuum extraction compared with forceps at preterm gestational age. Vacuum birth should be avoided below 32 weeks of gestation.
Try to be also near to your router, Dr. Adila, so I can hear you well. Okay, you answer or still? You answer the question?
Okay, the answer will be A. Vacuum
Try to be near to your router so I can hear you well also. Or you can hear both of us. You can hear both of us.
Okay. The answer will be A.
Okay. What is your answer?
A. Below 32 weeks.
What is your answer?
A.
So your answer is A?
Yeah.
Your answer
below,
A?
Yes, below 32 weeks of gestation.
Dr. Adil, your answer is A?
Yes, A. Yeah.
Okay, so please try to be near, because there is much interruption in your voice, Dr. Adila. Much interruption. Just a minute. Wait, just a minute. I will try to do something. Just a minute. Just a minute.
My answer will be A. Below 32 weeks of gestation. Hello?
Now sound is clear or still?
The sound is clear, Dr. Agada. Yes.
I'm suffering here. Okay, now I just a minute. Okay, so this is below 32 weeks. You remember the old guideline? It was less than 34. So now it's less than 32. Okay. Next, this is very important information. Be careful. Okay. Yeah. So abortive vaginal delivery should be take care. Should be avoided below 32 weeks. Not recommended. Why? Because below 32 weeks, this will increase the risk for the baby. Like cephalohematoma, intracranial hemorrhage, subgaleal hemorrhage, neonatal jaundice, and even this can lead to baby to have a shock and even die. So avoid the abortive vaginal delivery below, the vacuum extractor, avoid the vacuum extractor before 32 weeks. Caution from 32 to 36. Take care from the word. Avoid below 32. Caution from 32 to 36 weeks. Don't forget this information at all in the exam, because this will be very important. Next question. It not appear or what? Next question.
Yes. Which of the following correct answer? Clinicians should be aware that ultrasound assessment of the fetal head position prior to assisted vaginal birth is more reliable than clinical examination. It is recommended the routine use of abdominal or perineal ultrasound for assessment of the station. It is recommended the routine use of abdominal or perineal ultrasound for assessment, flexion, and descent of the fetal head in the second stage of labor. The correct answer, C. It is recommended the routine use of abdominal or perineal ultrasound for assessment, flexion, and descent of the fetal head in the second stage of labor.
Okay, so this will be a wrong answer. So the answer is A. They will use the ultrasound. They will use the ultrasound to check the fetal position. Put this one as a rule. Only position. They will check only the position. Anything others, they will insufficient evidence to check the station, insufficient evidence to check the flexion, insufficient evidence to check the descent of the head. So just something only one. What will be the ultrasound will be checked? Position. Yes. This will be more reliable than clinical examination. Be careful. Ultrasound for position. Okay. You can see the screen or move slowly.
Okay. Backup plan theater facilities should be available to allow a cesarean birth to be performed without delay in all operative vaginal delivery, mid-pelvic births, ventouse delivery, low forceps.
Okay. So which one?
Go for A, all operative vaginal delivery.
So another wrong answer. Backup plan that you need to make a cesarean section should be ready. That there will be high failure rate. So you can't do vaginal delivery. This will be a cost. Just in mid-pelvic birth, you need to do backup plan. Clear? Don't forget any informations. If you discuss and you may even answer it now wrong, you will not forget it in the exam.
Yeah.
Okay. Next.
I can give chance to another member to share as well.
No, you will answer this one. Don't worry. You can answer this one. No problem. We have today more than 60 questions, so you can answer this one. And don't be upset if you answer 2 questions wrong. Okay.
Okay. Moderate molding or +2 molding is where the parietal bone are overlapped but easily reduced, or where the parietal bone have overlapped and are irreducible, indicating cephalopelvic. +2 molding is A, when it is easily reducible, and +3 is B, when it is indicate cephalopelvic disproportion.
Excellent, Dr. Adila. So it's just 2 questions wrong, no problem. I am sure if these questions appear in the exam, you will never answer it wrong. Moderate, +2, or severe, 3. So +2, moderate, and +3 molding is severe. If there is reducible biparietal bone overlap, in both biparietal bone overlap, but if it is reducible, this will be +2. If irreducible, so it's +3. In +3, this is main indicate cephalopelvic disproportion. So if he give you a case of severe molding, you can't apply operative vaginal delivery. So if he give you this patient like moderate molding, so moderate molding mean or +2 molding you can apply. But in +3, this is indicate that this patient there is cephalopelvic disproportion. You should not apply operative vaginal delivery. Thank you, Dr. Adila, for sharing. It's really excellent. You already talked about moving from just 2 was wrong. Okay. Anyone wanted to share another one?
Ma'am, I'll volunteer.
Can I share?
Okay. What is your name, Dr.
Ankita.
Gita?
Ankita, yes, ma'am.
What is your name? Okay, you
Ankita,
are
ma'am.
from India?
Yes, ma'am.
Okay. Okay. Dr. Ankita from India. Okay. So, just a minute. Just a minute. There will be a safety criteria for applying the forceps or ventouse. Just if in between, just mute yourself. Dr. Ankita, she will be the next
Yes.
one. Just I will mute yourself in between so the sound will be clear. There is
Yes,
safety
ma'am.
criteria for applying operative assisted vaginal birth. You should examine the patient abdominally. If there is only 1/5 or less bears the abdomen, so you can apply. Cervix fully dilated, we just now tell you can't apply ventouse or forceps if the cervix not fully dilated. Stations at the level of the ischial spine or below. So from 0, +1, +2, you can apply. So from 0, you can apply operative vaginal delivery. A position of the head, knowing you know the position. Okay, you should know the position, and we just tell now if you are not confirmed, the ultrasound more reliable than the clinical examination. A clear explanation. This is a patient when you are decide to apply for her certain operative vaginal delivery. Just I will discuss with her informed consent. It can be just I will remove the messenger. Let's see one more. Okay, just I remove them. Just a minute. Okay. Okay. So, just mute yourself, doctor, please. Just mute yourself so we can finish working. Doctor, please. Can you mute yourself all, please? So the point here, fetal position knowing, molding you take. Be careful. No more than +2. +2. Please, if you possible, mute yourself, please, because we don't want to waste much time. This will be long, so we don't want to waste much time. So please, if possible, mute yourself. So if +2, you can apply in the exam. If you will choose operative vaginal delivery. +3, don't choose operative vaginal delivery. So moderate, +2, you can apply. Pelvic adequate, informed consent from the patient. Patient should be discussed. We talk about verbal or written forceps. Patient should be cooperative, not only no, she should be cooperative and talking to her how it will be applied, so she will help you during the operative vaginal delivery. Analgesia, we mentioned the analgesia. If the mid cavity or rotational, we are going to do a regional block, or if you are in hurry for urgency, duodenal block. You should empty the bladder, but if there is catheter, you are insert the catheter for any other reason, you should deflate the balloon. So you can't apply operative vaginal delivery while the balloon is there. So you should deflate the balloon. Sure, the one will apply the operative vaginal delivery should be operator, and he have also experience how to apply, because this will increase the rate of success. Backup plan. Only you are going to prepare for cesarean section for mid-pelvic birth. Antiseptic complication. I'm going to imagine yourself in the delivery room. I will apply now forceps or ventouse. So this baby could have shoulder dystocia during delivery. If shoulder dystocia, this will lead to increase the risk of perineal trauma, and this will increase the risk of postpartum hemorrhage. Make a story for yourself, because usually your memory not work in the exam. Shoulder dystocia, perineal trauma, postpartum hemorrhage, easy. And there should be a person present trained in the neonatal resuscitation, because this baby could deliver sick or with low Apgar score and need immediate resuscitation. High failure rate when? High failure rate if the body mass index for the patient more than 30. So you are now in duty in delivery room, you are sitting, and the midwife, she tell you already there is one patient admitted body mass index more than 30. Oh, so there is increased risk. This patient could need, in case if she need operative vaginal delivery, the failure will be high. Baby weight more than 4 kilograms. Oh, so this is patient if need also operative, there will be high risk too. She is also short, doctor. Oh, even this will be also increase the risk. So the high rate will be if the body mass index more than 30, fetal weight more than 4 kilogram, short stature, head circumference more than 95th centile, patient exhibit to posterior position the baby. This is also increase the risk of failure and mid-pelvic birth. And for this, we are doing backup plan. So why? Because there is high rate of failure. Okay, Dr. Antika, you are here?
Ma'am, I'm here.
Yes, okay.
Yes, ma'am. So, maximum pool of complete vacuum assisted birth with a maximum to bring the fetal head onto the perineum and the ease of the fetal head out of the perineum. It should be maximum 3 pulls.
It
D.
should be
D, ma'am.
maximum D. Okay, so
D,
this is
3
a
pulls.
wrong answer. Wrong answer.
Ideally, it should be.
6 balls.
Okay, ma'am.
6 balls. I will tell you why. Just a minute. Answer this one before I tell you why. Next, where are you? Where are you?
I'm here.
Where
Yes,
you
ma'am.
go? Okay, next question.
Maximum pool of complete vacuum assisted birth with a maximum of to bring the fetal head onto the perineum. Ma'am, I'm still think it should be 3.
Okay, so this is correct answer. You are correct. It's 3. So what is this? What is 6 and what is 3? Okay, be careful. Look again. If he tell you how much you can apply vacuum to bring the baby head to the perineum, 3 balls. You already know how many balls you did? 3. Still the baby on the perineum, but not outside. You don't want only to bring him to the perineum. You want to bring him outside. So they add here 3 additional gentle ball to ease the head to be delivered in the perineum. So how much? How much total? 6. 3 to bring the baby on the perineum, and the 3 gentle balls outside to ease the baby head on the perineum. Easy? Easy?
Okay, ma'am. Yes, ma'am.
So it's clear. If he gives you only one, if he gives you baby now on the perineum, how much balls you need outside? So 3 outside. If he didn't give, still you need to give both. So it's 6. Easy, not difficult. So
Yes,
3
ma'am.
balls to bring the baby head in the perineum. I can add 3 more if I wanted to deliver the baby head easily out the perineum. Okay, next.
During application of a vacuum, the operator should consider whether the application is suboptimal, the fetal position has been incorrectly diagnosed, or there is a CPD, and a less experienced operator should stop and seek a second opinion. It should be after 2 pulls.
After 2 pulls. Okay, correct. So if there is one apply already vacuum, and after 2 pull, still there is suboptimal decrease of the fetal head, so still 1. So it's better to ask a second opinion to check if he are going to complete the procedure also. So after 2 pull, he should call a senior. Okay, so minimal descent. After 2 ball, operator should consider whether application is suboptimal or fetal position has been incorrectly diagnosed, or there is cephalopelvic disproportion. So less experienced operator should stop and seek second opinion. It will be a safer option for the patient. So the experienced operator will come, he will re-evaluate the patient again if he wanted to continue the procedure or he can stop this procedure.
Discontinue vacuum assisted birth if there has been of the instruments. It should be 2 pop-ups. Vacuum assisted birth if there has been yes ma'am, it should be 2 pop-up. 2 pop-up and 3 pull. 2 pop-up. B.
So how many you will choose which one, A or B or C?
B, ma'am. B. 2 pop-ups. 2 pop-ups.
Two pops. So should discontinue the vacuum after 2 pops. 2 pops mean pops of detached. You are applying detached. Okay? the vacuum cup detached from the fetal head. So after 2 pop-offs, you should stop the procedure. Okay. Where are you? Where are you, Disney? Okay, you are muted. Okay, no problem.
Yes, ma'am. Less experienced. Yes,
Okay.
ma'am. Less experienced operators should seek senior support in case of pop-up to ensure the woman has the best chance of successful cesarean vaginal birth. It should be after 1 pop-off, ma'am. It should be A.
After, yes, because already we tell we will stop after 2, so don't waste the other one. Call another one to not lose the for this patient, because we will stop after 2 pop-off. So if less experience, one must call a second opinion for this patient. So this is if you again, you will mute yourself now. Okay, so the sound, because there is much noise. Okay, discontinue the vacuum after 2 pop-off. And if there is one less experience, he after just 1 pop-off, he just will call another senior, so he can evaluate the patient again before applying the ventouse again. As they compare the rapid negative pressure application compared to stepwise for vacuum-assisted birth, they tell just it reduce the procedure duration, just because you are doing fast rapid negative pressure. This is just will make the procedure shorter, but no difference in the maternal and fetal outcome. So you know, all of you, that the pressure will be until 0 to 8 kilogram. The use of sequential instrument, that you can use ventouse and ventouse fail, and after this an obstetrician decide to apply forceps. So if you are using two instruments, this is will increase the risk of trauma to the infant. And also in the same time, be careful if you are trying to deliver this baby from down. You are trying. You should be careful. Why should be careful? Because if you make the head impacted in the pelvis and the instrument delivery fail, it will be very difficult to also to deliver this baby by cesarean section. It will be very difficult to how you will bring a baby head very impacted down. It will be difficult, and you need again maybe a procedure inside the theater to disimpact the fetal head from the pelvis. So again, make it very clear for yourself to be easy. After 1 pop-off, if less experienced operator, he will call a senior. It's easy. You will discontinue vacuum after 2 pop-off. Easy. 1 and 2. 3 balls and 3 balls. 3 balls, you can use vacuum for 3 balls until you bring the fetal head and the perineum. You can use again 3 more ball, gentle ball, to bring the baby head outside. So the total you can use, it's 6. 2 ball, if I am a doctor, I am applying already the vacuum, not detached, so I can try 2 times. After 2 times, the fetal head not come, so I need to evaluate what is the problem. Maybe the position not correct, and I should seek another opinion before I apply the 3rd one. It's easy. Just this is the summary. Be careful. You can face any of these in the exam. Obstetrician should be aware about increasing neonatal morbidity following vacuum, failed vacuum-assisted birth and sequential use of an instrument, and should inform the neonatology doctor to be there to evaluate the baby after delivery. Obstetrician also should be aware increase the risk of obstetric anal sphincter, especially if you are using more than 1 instrument, and the perineal trauma will be more sure with the forceps. Okay.
During application, duration of application was associated with an increased risk of composite neonatal adverse outcome for greater than 12 minutes, 5 minutes, 10 minutes. I'm confused between A and C, ma'am.
A and C, ma'am. So in the exam, you should choose.
So yeah, I'll go with A.
A. Okay, so you get the mark. You see, I don't know the answer, but still I get the mark. Correct. So greater than 12 minutes. Okay, so the duration of application increase the adverse effect for the neonatal will be if the application more than 12 minutes. Okay, I need to slow the slides because this will not appear. Okay, episiotomy, there is no regarding the episiotomy, it could be not essential to do episiotomy for the patient. Just you need to evaluate the episiotomy will be needed or not. But if you have one patient, sure, you will apply forceps, and this is a case not delivered before, so sure you will do episiotomy because this is will decrease the risk for this patient. Read slowly. You mean she is an Ankita to read slowly. Okay, so I read good or I will need to read slowly. Okay. They want from you to read slowly. Okay. Mediolateral episiotomy, it will be logic to apply for the patient to prevent if she don't deliver before. She don't deliver before. Okay. Just you need to listen the record frequent time. Okay, you need to listen the record. There is some, if first time I will hear this information, it will be difficult. But when I repeat again listening, it will be very easy. So don't worry. Okay, so don't worry. So mediolateral episiotomy, it will be better if the patient you are going to deliver her forceps and she don't deliver before, because this will decrease the risk for her to have obstetric anal sphincter injury. Sure, when we are going to do episiotomy, it will be 60 degrees when the perineum is stretched. After any patient to deliver, you should assess the risk of thromboprophylaxis if this patient you are going to give her low molecular weight heparin or no, according to the thromboprophylaxis guideline. You should also aware that this patient also at high risk to have urine retention. So it's very important to record the time and volume, both time and volume, and monitor this one, and should be documented in the patient file. If I am suspecting that this patient could have urine retention, so post-voidal residual volume should be measured. So to decrease the risk of incontinence, because after operative for renal delivery, maybe this patient she can has urinary incontinence after delivery, especially at 3 months. So directly this patient she can offer physiotherapy, because this will decrease the risk for her to have urinary incontinence at 3 months. Regarding the retention, if you have one patient, she already received epidural, so it's better to insert the catheter for her at least 6 to 12 hours. And according to the hospital protocol, some hospital can make only 6 hours and remove, other hospital 8 hours, other hospital 12. But how much should be? Not less than 6 hours. If you remove the catheter less than 6 hours, this will increase the risk for the patient to have retention. For the patient normal delivery, I think there is some articles talking about this point. If you have one patient normal delivery, deliver normal. She don't use any epidural. You should encourage her before 6 hours to pass urine, because if she stay more than 6 hours without passing urine, this will increase the risk for her to have retention. But if she is receiving epidural, it will be difficult for her to move, and so it's better to keep the catheter 6 hours to make the urine drain. From 6 to 12 hours, this will decrease the risk for her to having asymptomatic bladder overfilling. Okay, next.
Yes, ma'am. Women post-operative vaginal delivery day 2 who have a traumatic birth offer advice and support, no action, refer to skilled professionals. It should be A. I will read the question again. Women post-operative vaginal delivery day 2 who have had a traumatic birth, A. Offer advice and support, no action, referral to skilled professionals. I will go with A, ma'am. A. Offer advice and support.
Okay, so if the patient after delivery, she can have traumatic birth. So the first point, advice and support. Okay, step by step. Don't go and rush to use that I will refer her. No. Just I need after this patient delivered, the one who delivers the patient, it's better. This will be a good practice. He should be the one to visit the patient next day and see her before discharge and talking again, because yes, you discuss with her before delivery and you take her consent, but will be a stressful time for her. But after delivery, already she don't have pain. I will visit her. I will see her how she is doing. Any complaint, I will discuss with her why the instrument delivery, how she is feeling, how will be her future birth. This will give very good impression. And in the same time, it's better to be by the one who delivers the patient. So if the patient, she has a traumatic birth, this can happen after delivery. So just advise her and support. Don't offer her single session. No need. Just if after 1 month, still she has post-traumatic stress disorder, after 1 month, you will refer her to a skilled professionals as per NICE guideline. Okay. And inform the woman that there is high probability of spontaneous vaginal birth in subsequent labors. Like if she tell you, doctor, I wanted to know what will be the spontaneous, I have a chance, I will deliver normal delivery or no. Yes, there is very high chance, and we will discuss it. Just a minute, we will discuss this point now. After delivery of any baby, you need to send birth blood sample. And also if there is any adverse outcome like failed instrument delivery, like major postpartum hemorrhage, like obstetric anal sphincter injury, like shoulder dystocia, significant neonatal complication, you should write incidence report as a part of risk management process to check why this one happened and how to avoid to occur again in the future. Duty of condor, you are be honest with the patient. If there is a complication happen, you should be honest. You will tell her why this one happened to her clearly without hide any informations. So if she asks you, this is again the VBAC, this is another point. VBAC more likely to fail. If we are comparing the VBAC by with forceps, comparison between them. So in the VBAC more likely to fail, more likely to associated with cephalohematoma, more likely to associated with retinal hemorrhage, more likely to have maternal worries. So if you deliver one patient with ventouse and another one with by forceps, the one delivered by VBAC, she will be more worried about her baby, but less likely to have a maternal perineal and vaginal tears with ventouse. No more likely to be associated with cesarean section, no more likely low Apgar score at 5 minutes, no more likely to need phototherapy for the baby.
Yes, ma'am. Risk of obstetric and sphincter injury with operative vaginal delivery with vacuum 4% and forceps 10%. B, vacuum 10 and forceps 20. Answer should be A, ma'am. It is 1 to 4% with vacuum and 8 to 12% with forceps. So answer should be A.
A. So when you can choose the answer B, what will be the question for which you can choose answer B?
Ma'am, it's the perineal trauma. The chances of perineal trauma or the vaginal tear is 10% with vacuum and 20% with forceps.
Excellent. So if you ask about obstetric anal sphincter, so it will be 4 with vacuum and 10 with forceps. This was the correct information, but be careful. If he asks you about significant vulval and vaginal tear, he didn't mention here the obstetric anal sphincter. Be careful. So it will be 10 and 20. Both question is very important. So significant for vulvovaginal tears, it will be 10 and 20. The lower will be with the ventouse. It's easy. The lower will be with the ventouse. And the obstetric anal sphincter will be 4 and 8 to 12. This can be only a question. This one can be only a question. How much obstetric anal sphincter with forceps? He can give you 10 in the exam. Maybe he will not give you 8 to 12. No, he can give you 10. So it's in between, correct? So it's a 10, okay? Cephalohematoma can occur up to 12 also, and other complications. Next.
It is recommended following assisted vaginal birth, a single prophylactic dose of intravenous amoxicillin and clavulanic acid. Yes, it is recommended within 4 hours of assisted vaginal birth. It is true. Answer should be A, ma'am. A.
I don't have message notification. I think this is from Dr. I even removed my messenger now. I didn't have any message notification. Just mute your notification, Dr. Ankita. Just mute your notification of the message because this is too much noise. What is your answer? What is your answer?
Ma'am, it is A. Amoxicillin should be given within 4 hours. So it's A.
So it's the correct answer. Single prophylactic dose of intravenous amoxicillin and clavulanic acid. This will be reduce the risk of confirmed of suspected infection, and also you will provide the patient, any patient after delivery, you will give her non-steroidal or paracetamol if there is no any contraindication. Correct? Okay. So if the patient she tell you, doctor, I deliver this time with forceps, so next time I will deliver with forceps. No, you will tell her if this time you deliver with ventouse, the next time there is about 90% you will deliver spontaneous vaginal delivery. And if you have more complex operative vaginal delivery like mid cavity or in the theater, so it will be dropped to 80. So it's still high chance. So it's high chance to have a spontaneous vaginal birth in next delivery. This was assisted vaginal birth prenatal guidelines published on 28 April 2020. Just this is important, some important information. Sure, there is more important information, and this is the first time I read the guideline, but it will give you a guide how you are going to solve the questions, but please try to read it again and pick more important informations. We can give you also one chance. I think we can give you some questions again. Okay. So the patient, we are going to move to the next guideline, birth after previous cesarean section. Very important guideline. You can solve this question, Dr.
Yes, ma'am. Women should be informed that planned VBAC is associated with the risk of uterine rupture approximately. It's 0.5%, ma'am. So yes, it's A. 1 upon 200.
Yes, it's less than 1 every 200, so it's a correct answer. 0.5 if it is come in the exam, or 1 every 200. So it's the correct answer. I should move slowly because the answer will appear in the PDF. Okay. Okay, next.
Men with 2 previous cesarean deliveries who are considering VBAC should be counseled about the risk of uterine rupture. It's D. 5%. No, ma'am, no, it's 5% when there is a case of previous rupture. It's not D. It's A or B. It's A, ma'am. It's A.
A. So the risk of rupture after previous 2 cesarean section, it will be 1.3. Now, just mute your message notification. Mute your message. We will have headache after the session. Okay. So if you have one patient in your daily life, you meet her, just you will remember this patient previous one, so the risk of rupture will be 0.5. If she has previous 2 cesarean section, it will be 1.36, just 1.3. Okay, so it's easy, don't forget. Okay, next.
So patient who have experienced the previous uterine rupture, the risk of recurrent uterine rupture with labor is 5%. It's A, ma'am.
5%. So if you have one patient with history of previous rupture uterus during delivery, so the risk of rupture this time, it will be reached to 5%. So it will be higher. So 5% if the patient she has, and this will be a contraindication for VBAC. And also one of the contraindication for VBAC, if the patient already she has absolute contraindication, like she is a case of major placenta previa, so this is not for VBAC. So it could be another reason not related to the cesarean section, but she has another reason make the cesarean section also vaginal delivery contraindicated for her. Thank you, Dr. Ankita, for sharing. We can give a chance for any others. Anyone want to share? Others?
Thank you, ma'am.
Thank you. Any others? Any
Can I
other
share,
one
ma'am?
want to share? Yes, what is your name?
Can I
Selma.
share?
Dr. Salma, yes. Because Dr. Salma, yes, you asked before. Okay, Dr. Salma. Okay, we will move to the next. Okay, just to be easy for you, I just put summary for all of you. It's to be easy. Patient rupture after previous one cesarean section, 1 every 200. After previous 2 cesarean section, 1 every. Dr. Salma, just mute yourself once the question comes, just to open your mic. After previous 2 cesarean section, 1.3. After previous uterine rupture, 5%. So what about patient primary? She don't have any scar. What about if the patient tell you, I don't want to doctor vaginal delivery, just book me for elective cesarean section. So how much is it? Maybe during waiting for the elective cesarean section, maybe this patient rupture, she will ask you, so how much chance I will have rupture uterus while I am waiting for elective cesarean section? So it's almost the same in the primary gravida. It's about 2 every 10,000, mean 0.02%. This is just a summary. It's easy. 1 every 200, previous one. 1.36, previous 2, 5%, previous rupture. Elective cesarean section, a patient for booking for elective cesarean section, she has previous cesarean section and she is waiting for cesarean section. Primary gravida, it will be same, 2 per 10,000. It's about 0.02. Okay. Where are you? Where are you? Yes, now. Where are you?
The most consistent finding in uterine rupture is abnormal CTG.
Abnormal CTG, the most finding in uterine rupture, abnormal CTG. Correct answer. This is a correct answer. It's about in 76 of the patient, they have abnormal CTG. So your eyes on CTG of the patient. Your eyes on the CTG of the patient, because this will be give you impression that this is patient could rupture in the during labor. And they find that almost half of the cases there will be abdominal pain and
the bathroom. I finish my question, but then I come back. Huh? In the clinic there.
Dr. Salma, just mute yourself. So if you are want talking, so it will. Okay. So the CTG, the most common feature, abnormal CTG, but half of the cases rupture, there will be abdominal pain and abnormal CTG. Be careful. The commonest abnormal CTG, but in 0.5%, there will be abnormal CTG and abdominal pain. In the exam, you will be confused. Bleeding, pain, what? Okay, so be careful and concentrate. It's easy. Next. Salma, where are you?
Most uterine rupture occur during labor, the peak incidence being at 5 cm cervical dilatation.
At 5 centimeter, excellent, correct answer. It's in about at 4 to 5 centimeter. But just I put 5 centimeter just to remember. But usually the rupture will occur at 4 to 5%, 4 to 5 centimeter. 90% of the cases will be rupture. 18 and 8. 18 will rupture during the second stage of labor. 8, they will recognize that the patient rupture after delivery. So what is the features? What is the feature? Patient, you have now patient in labor. She is previous cesarean section. Just to be careful. You look CTG abnormal, so this patient could associated with uterine rupture. Severe abdominal pain, especially persistence in between contractions. This could be also uterine rupture. Acute onset of scar tenderness. Abnormal vaginal bleeding. She started to bleed. Hematuria. You can see blood in her urine. Cessation of efficient uterine activity. Patient, she has very good contractions, then stop. Uterus rupture. Maternal tachycardia. Her vitals pulse become very high. Hypotensive. Patient bleed. Fainting. Shock. Patient, you are delivering a patient with previous cesarean section and the head in front you. Suddenly the head disappear. Uterus rupture. Change the abdominal contour and inability to make the fetal heart at the same old transducer site. What is the difference between uterine rupture and adhesions? Uterine rupture, already the muscle is disturbed already, and also the uterine cirrhosis. But if the uterine cirrhosis is intact and the muscle only, disruption of the muscle only, and cirrhosis intact, this would be uterine adhesions. If the patient she is taking she is VBAC, you can give her epidural, no problem. But increase the requirement of the pain relief. This could raise the possibility of uterine rupture. So be careful. Just put in your mind, if she is complaining much pain, this patient could rupture. Be careful. Regarding the respiratory distress, this is important question. Why they are delivering the patient after 39 weeks? Because when they are comparing cesarean section at 37, at 38, at 39, they find that the risk of respiratory distress at 37 it will be 11, at 38 it will be 6, at 39 it will be 1. Make it 1 to make it is easy. 11 and 1 or 11.5 if you can remember. So the less respiratory distress will be at 39 weeks. So the advice any patient to, if she wants for elective cesarean section, should be 39 and above, because this will be decrease the risk of respiratory distress. 11, 6, 1.5. Next.
VBAC success rate with the previous cesarean section is 72 to 75%.
72 to 75%. Excellent. Correct. So if you have one patient now, she asks you, doctor, I have a previous cesarean section. How much chance generally? You don't ask her what is the reason of previous cesarean section. Just she wanted to know the chance. So it will be 72 to 75. Try to use the same information in your daily life with your patient, so you can remember easily in the exam. So the patient, you will give her correct information, and also this will help you to pass in the exam. Next.
VBAC, same slide.
No, this is previous.
VBAC, VBAC success rate with the 2 previous cesarean births.
Be careful in the exam to read the question carefully. Read the question carefully in the exam, otherwise you will answer wrong.
I think 50 to 60%.
50 to 60. Okay, so previous to cesarean section, it's 62 to 75. The success rate after previous to cesarean sections was still high. It's about 71. Okay.
Gravid Barawan previous CS due to labor dystocia. Want to know her chance to have successful VBAC. If due to labor dystocia, low success rate around 60%.
60%, correct answer? 60%. So how I will remember in the exam? Just I will put in myself. If this patient, she has previous cesarean section and she deliver vaginal delivery after the cesarean section, the success rate will reach to 90. If the patient, she tell you, I deliver last delivery because my baby was breech, so 85, make it 85, make it 84, no problem. So make it 90, 85, 73, fetal distress, labor dystocia, 64, failed instrument delivery, 61, If the patient, you induce her, she is not in labor, and you give her induction of labor, and her body mass index higher than 30, and she has previous delivery because shoulder labor dystocia, the success rate will drop to 40, 90, 85. I make it like this in my before my exam. I make it 90, 85, 75, 65, 60, 40. So I will remember my head not computer. I'm not a computer, but I wanted to pass, and they will give me a question in the exam, and they will ask me the success rate. So maybe I need this mark only to pass. Easy or not easy? Not easy. Okay. So the previous cesarean section, important points in the history. If you have one patient in your clinic now, you need to ask her why you have cesarean section last time, because you wanted to know how much success rate. Maybe there is a contraindication. Maybe she has a rupture in the last time. What is the problem happened to her during the delivery? I can go through her notes in the surgery notes. Any problem? What is the cesarean section scar? Because maybe she has longitudinal scar, and this is also a contraindication for VBAC. Any complication for the baby? She tell you, my baby now he has cerebral palsy. My baby died, doctor, during the delivery. So fetal outcome is very important and very essential to discuss with the patient in her history.
Antenatal counseling appointment for women with uncomplicated single-term pregnancies and single previous lower segment cesarean section delivery, to counsel her about risk and benefit of VBAC versus elective repeated cesarean section. At booking.
At booking. Okay, so this is a wrong information. It's at 21.
At 36 we'll decide.
Okay, no problem. We are here. If you did it, if you answer wrong, it will be good, because you will not forget in the exam. At booking the correct, you will give her patient information leaflet written. She will take at home and she will read. She will have idea about VBAC and elective repeated cesarean section. At anomaly scan, make it at anomaly scan. Anomaly scan 21 to 20, scan until anomaly until 20 plus 60 days. So from the last day of the anomaly scan, 21 to 28, I will counsel her about VBAC and elective repeated cesarean section, advantage and disadvantage, risk and benefits, and she will have idea. She will take decision at 36. Easy. Patient information leaflet at booking, counsel at 21 to 28 weeks, decision at 36 weeks. Easy?
Yes.
Easy. Okay, next.
Sterilization is to be performed at the same time as cesarean delivery. Counseling and agreement should have been given at least 3 weeks before operation.
3 weeks before operation. One patient, she will tell you, doctor, I don't want a VBAC because I want sterilization, so it's better to do for me cesarean section. So should be counseled at least 2 weeks before the procedure. Can't be in the same day of the surgery, so at least 2 weeks. Okay, easy. So if the patient don't want more fertility, so the cesarean section will be better for her because tubal ligation can be done, but we can discuss with her that the failure rate will be higher than the interval procedure. Next.
Pregnant women previous to CS, both were emergency CS and considered traumatic for her. She wants vaginal delivery in current pregnancy.
Okay.
Advice against, refer to another consultant for further counseling. Counsel about risk. Allow VBAC but no induction, no augmentation. Advice against.
I am a patient. I have already previous to cesarean section. I want to deliver normal delivery. So what you are going to tell me, I will counsel about the risk. I will counsel about the risk. In the end, she can have a chance to deliver, but after you inform her what will be the benefit and risk. You will not refer her to the consultant. You can counsel the patient. You can refer to the consultant if you counsel her and still she wanted to for vaginal delivery. You can offer her appointment with the consultant. But right now, you need to counsel the risk. Maybe when she knows the risk, okay, no, I don't know this doctor, so I want cesarean section. No, doctor, I also still want vaginal delivery. So counsel about the risk. This will be the first step, okay? And you can't advise against what against you. If you advise against what, you know what this means. If you advise against, this means that you take the decision for the patient, and this should not be done at all. You should not take decision for the patient. You will tell her at the end, it will be the patient decision. Be careful. Okay. Counsel about the risk. So VBAC and elective repeated cesarean section, you should know what is the benefit and what will be the risk. Benefit, VBAC, the success rate 72 to 75. This means that 25% for the patient will need cesarean section emergency. Sometimes in the exam, this is happened. This is really happened. Like the patient, he will ask you the success rate. I know the success rate 75. And when he asks you how much percent this patient she will need emergency cesarean section during labor, during VBAC, from where is this information? So he already knows that the success rate 75. So the cesarean section will be 25. Just saying, okay? Shorter hospital stay, greater likelihood of future vaginal delivery. Risk, there will be uterine rupture 1 every 200, less than 1 every 200. And this will lead to maternal morbidity and also mortality. Risk of anal sphincter injury. Just mute yourself, Dr. Salma, and again you will open when the question comes. Dr. Benit, please you mute yourself. Dr. Benit, please mute yourself. Benit Hawa. Dr. Benit Hawa. Hello? Dr. Benit, can you mute yourself? Okay, so the risk of the uterine rupture will be about 5%. Dr. Benit, can you mute yourself, please? Dr. Benit. Dr. Ben. Oh my God. Okay, so the risk of sphincter injury, it will be about 5%. And the risk of instrument delivery will be 269. I don't know, the problem is if you are not concentrated in the meeting and you will disturb the sound and we can't, even I can't hear myself. So Dr. Blue, please, if you possible, you can mute yourself, please. Dr. Blue. Dr. Blue, can you mute yourself, please? Dr. Bent, can you mute yourself, please? Dr. Bent, hello? Okay, the risk of anal sphincter will be about 5%, and the need for instrument delivery during delivery, it will be reached to 39. For the patient with elective cesarean section, the benefit that you will avoid the rupture will be reduce the risk of pelvic floor prolapse and urinary incontinence. And if the patient she wish to have sterilization, this will be an option for her if she don't want fertility no more. The risk in the future pregnancy, she will need more again cesarean section, risk of placenta previa, less risk of placenta accreta, and also there will be adhesion. Elective cesarean section and the VBAC, when they compare the fetal distress, make it 6 and 3. After elective cesarean section 6, and after vaginal delivery 3, so it's half. So in the VBAC, the respiratory distress will be lower. Dr. Bent, you will spoil the session if you are keeping your mic, and really I can't do in the meeting to remove someone from the meeting. So please, if you can mute your mic. Okay, next question.
Patients for elective cesarean section at 38 weeks need to know how much steroid will reduce respiratory morbidity at this gestational age. 4 to 6%.
50%. If you are giving a steroid to the patient for cesarean section, this will reduce the respiratory morbidity for the patient by about 50%. I don't know how to mute others. I will learn, but I don't know how to mute or remove anyone. I can't remove anyone from the meeting, but I don't know still. This will waste time in the session. Okay, next. So 50% is the previous question. The answer 50%. Okay, next.
The single best predictor of successful VBAC, previous VBAC.
Previous VBAC. This is the best predictor for successful VBAC. Excellent.
Patient gravid 3 bar 2 39 weeks first delivery cesarean section second VBAC. Ask about her chance successful VBAC in the current pregnancy. It can reach until 85 to 90%.
Yes, because she already delivered we reached to 90%. Excellent. I think we put it in the table before, so it's easy now.
Women scheduled for elective repeated cesarean section want to know the chance to go into labor before 39 weeks. It is 10%.
10%. So if one patient she tell you I want elective repeated cesarean section, doctor, how much chance I will have labor pain before 39 weeks? So it will be 10%. Excellent. And also should be a plan documented in the file. You will tell her, so in case you come in labor, so what will be the plan? You wanted to take the vaginal, you should document. She refused to take the trial if she come in labor. No, she agreed to take a trial. So the plan, in case she come in emergency in labor, should be also discussed and documented. So the contraindication we tell before, maybe there is a contraindication for VBAC like placenta brevia or accreta. We need to look to the record abortive vaginal delivery. Maybe there is a contraindication for this patient like longitudinal incision or extension. If there is any other medical or obstetric reason, pre-include the VBAC. Maybe there is another contraindication. Increase the success rate when this patient, I will tell this patient more high success rate during VBAC. I just make it as a story. Before our exam also we are making a story. We can just mute yourself, Dr. Salma, until the next question. Decrease the noise. Dr. Salma and Dr. Benit. Still, Dr. Benit, your mic is. Dr. Salma, can you mute your mic to check from where is
No, my mic muted, Dr. Ghada. I'm not the one. I already closed it after the question.
So just I make it as a story. We can say that a man, he will like the woman if she is greater height, if her age less than 40, if her body mass index she is slim less than 30, and also in top article it's written it will be more successful if she is white one. Also the man will like the white one. They will not like the others. This is just a story, okay? Make it as a story just to remember, okay? I don't know if anyone, I don't know how to mute one. I don't know, Dr. Demetrius spoiled all the session. I don't know if there is any way I will try, but I don't know really. I don't know. I'm not familiar how I will. Okay, but the sound is clear. We can continue like this, so we will not lose the time. We can continue like this, okay? And also, if the baby less than 4 kilograms, this is also will increase the likelihood for the VBAC, and if the gestational age less than 40. Successful VBAC will be highest in the fetal malpresentation. It will be 84, except if the patient also has a history of vaginal delivery, it will be increased to 84. Intrapartum, you should monitor the patient vital CTG because you want to know this patient could have rupture. You should careful regarding the failure of progress because this could increase the risk of rupture of this patient. Should be careful for augmentation for this patient because this can increase the risk of rupture. If you have one patient, she tell you, I have a history of hysteroscopic resection of septum. I have uterine septum and already surgery done and remove this septum. This patient, and she don't have any history of cesarean section at all before. This patient in labor, you will deal with her similarly like the patient with VBAC. So if she has a hysteroscopic resection of uterine septum, so the same you will deal with this patient as VBAC. Be careful. He can give you a patient primary gravida. She don't have any problem. Hysteroscopic resection. So this patient is a case of VBAC. Okay, next.
The risk of blood transfusion will be higher in cesarean section.
Blood transfusion is higher in cesarean section. Wrong information. It's higher in the VBAC. I just put it because I know that you will tell cesarean section. You are thinking that the cesarean section, the bleeding will be more in the cesarean. No, the risk of the blood transfusion I will tell you this guideline full of numbers. Okay, you can't know everything. You are not a computer, but there is something easy. There is something easy you can remember, like the percentage of success you can use in your clinic daily life. So it will be easy. Even the patient, she will ask you, so you should give her correct answer. Blood transfusion in the VBAC, it will be 2%. After elective cesarean section, after repeated cesarean section, it will be 1. So it will be double in the VBAC. Be careful. I just put it to be careful. To be careful. Okay. Respiratory distress, we mentioned this point before. 3% in the VBAC and 60% in the cesarean section. So it's a double in the cesarean section.
Contraindication for VBAC according to the NICE guideline. More than 3 CS, more than 2 CS. يعني
okay, according to the NICE guideline, more than 4. More than 4. This information I just put because they are giving in the NICE guideline very small information. They tell inform woman who had up to, including 4 cesarean section, that the risk of fever, bladder injury, surgical injuries does not vary with the planned mode of delivery, and that is the risk of the rupture of, although the risk of rupture will be higher for planned VBAC, it will be rare. So he wanted to tell in the end that the risk will be rare in the previous 4 cesarean section, just to know the information for your knowledge that according to the NICE guideline, the contraindication, because he gave you until 4 cesarean section, when they do comparison regarding the mode of delivery, there is no variable, even the risk of rupture is rare. So we wanted to tell you until 4 previous cesarean section patient can have a trial. So this is just the information in the NICE guideline, but usually in your daily life, you can give 1 or maximum 2 cesarean section. Okay, next.
The risk of stillbirth at or after 39 weeks is higher in women with previous cesarean delivery compared with women without previous cesarean delivery.
So the patient she has previous cesarean section, she can have stillbirth more. She can have stillbirth more about 2-fold. So you will tell her that there is increase. When you are counseling the patient, even for cesarean section, you will tell her in the future pregnancy, there is 2-fold increase of the stillbirth comparing to the other woman without previous cesarean section. 2-fold. Okay, so the induction of labor, if you are going to do induction for labor, this will increase the risk of rupture and increase the risk of emergency cesarean section because she is already not in labor. So make it, if you are going induction, so 1.5-fold increase this patient, she will need emergency cesarean. So double, 3-fold she will rupture during the labor. What is also planned VBAC, complicated if the patient post-date, if the patient she has twins gestation, if the baby fetal macrosomia, if there is antepartum stillbirth, if maternal age 40 or more, this is all can be complicated the VBAC. Regarding the preterm, success rate similar the term, but the rupture will be less. Be careful. The rupture will be less than at term, so the success rate will be similar. So if he give you a scenario of preterm and he ask you regarding the success rate, so it will be similar. This is source information, the VBAC guideline, October 2015. Thank you, Dr. Salma, for sharing. We can give a chance for others who wanted to share. Next guideline.
Hello.
Yes.
Yes.
Shoulder dystocia.
I'm Dr. Sumaya.
Yes, Dr. Sumaya. Shoulder dystocia.
Okay. Okay.
Next.
Conventional risk factor predicted in how much percentage of shoulder dystocia that resulted in infant morbidity. It's 16%.
16%. So the risk factors can be predicted only in 16%. So this is something unpredictable, because most of the cases you can't predict that this patient can have shoulder dystocia, correct? Shoulder dystocia, when you have vaginal cephalic births, that require additional obstetric maneuver to deliver the baby shoulder after the baby head delivered. Objective diagnosis, if there is prolongation of the baby head to body delivery more than 60 seconds, but it is not routinely collected, this data. Shoulder dystocia can be either the anterior shoulder or the posterior shoulder. Either it will be stuck behind the symphysis pubis, sacral promontory, or maternal symphysis. It will be obstructed there. Risk factors will be predicted in 16% only. Other cases you can't predict that this patient she has shoulder dystocia. Be careful. Be careful. Babies more than 4.5 kilogram not develop shoulder dystocia. Large majority. So don't think that this baby, 4.5 he will have. No. Majority of these babies, they will not develop shoulder dystocia. Almost 50% of the babies, they will develop shoulder dystocia. The weight will be less than 4 kilogram. Be careful. Okay, next. Next.
What is the risk of recurrence shoulder dystocia? It's tenfold. D.
Yes, recurrence. She can ask you recurrence of next pregnancy. You will have, yes, you will have tenfold increase. Correct. The factors associated with shoulder dystocia. So if you are in antenatal care, you can suspect this patient she can have shoulder dystocia. Yes. Pre-labor, if she has already history of shoulder dystocia, just now we tell tenfold increase. If she has macrosomia, her baby more than 4.5, but still we tell that majority of these babies, they will not have shoulder dystocia. If this patient, she has diabetes mellitus, this is increased the risk for her. If body mass index more than 30, if this patient you are going to do induction for labor for her, this is also will increase the risk of shoulder dystocia. So during labor, I can suspect this patient can have also shoulder dystocia. Yes. If the first stage prolonged, if the second stage prolonged, if there is secondary arrest, if you are using syntesinone, this patient will have also shoulder dystocia. If you are using, just now we tell assisted vaginal birth, abortive vaginal delivery, increase the risk of shoulder dystocia, increase the risk of perineal tears, increase the risk of postpartum hemorrhage. Okay, next.
Primigravida in labor during second stage of labor, Tuttle sign. Tuttle sign, first sign is McRoberts position.
Yes, the first action will be McRobert, but if there is call for help in this question, you will choose call for help first. If not there, so you will use McRobert position. Correct. MRCOG position, this is the fertile sign. This will be the fetal face and chin. It will be retracted behind the perineum as in the picture. Correct. Okay, next.
Incidence of shoulder dystocia. Report incidences is 7 per thousand.
Yes, incidence of shoulder dystocia, it's 7/1000. This is correct answer. It's about 0.7%. Excellent. Next.
Incidence of postpartum hemorrhage after shoulder dystocia, it's be 11%.
Excellent. 11%. This is a famous number in part 2. 11%. Also, there is some famous number 11. If you can remember, you will be very excellent. 11%. Anyone remember? Famous number.
Femoral
Femoral.
It's nerve
injury.
femoral nerve injury.
Femoral injury.
Femoral nerve injury. Two femur. So
Okay,
just remember
1.
11%, and incidence of postpartum hemorrhage also after shoulder dystocia 11%. Excellent. So the incidence of shoulder dystocia 7/1000, incidence of postpartum hemorrhage 11%. Fourth degree perineal tears, it will be about 3.8% after shoulder dystocia, and the complication of brachial plexus reach to 16%. Numbers, it's difficult. Some they don't have ability to save the number, but I think with the repetition, it will be very easy. Once you finish the exam, usually you will not remember any numbers. But just to prepare yourself, repeat it frequent time, so it will be easy. Next.
McRoberts maneuver position has been described. Success rate is C, 90%.
Excellent. McRobert maneuver, the success rate will be 90%. You will do axial direction, traction in the axial direction, and this is to deliver the baby shoulder.
All 4 technique, it's 83.
How much?
83. Actually, it is 85, but it is 83.
Correct. 83. The success rate of all 4 positions, it's 83. Correct. So if you have shoulder dystocia, the first step, you will need to call for help. This is the most important. You need to call for midwifery. You need to call for experienced midwife to be with you, experienced obstetrician, neonatal doctor, because he will be the one to resuscitate the baby, anesthetist doctor. You will stay when you are calling for help early in any emergency. This is will sure the outcome will be better. This is will improve the outcome. But if you delay to call, some they are shameful to call. This can affect the patient safety. So whenever you call early, it will be improve the outcome of this baby. Remember that this is bony obstruction. So the episiotomy just you can need for just the maneuver, but it is not remove the obstruction. Just if you will assess the internal maneuver, if you need it, you will do episiotomy. Don't forget to remove the pillow from the patient head. Don't forget to tell the patient the situation. It's not logic. A patient, she will have shoulder dystocia. She don't know anything. You are calling for help. Much persons coming inside the room. She don't know what is ongoing. What is the problem, doctor? And you don't inform her anything. You will tell her that the situation of her baby. You will ask her. You will remove the pillow from below her head. One of the assistants. And you will ask her stop to push, and the fundal push should not be done because this will lead to increase the risk of uterine rupture. Next, McRobert, as in the picture, flexion of the hip and the knee and abduction. This will lead to striated of the lumbosacral angle, and this will increase the diameter of the anterior posterior diameter of the pelvis relatively, and this can relieve the obstruction. This will be success. How much? Over 90% with axial traction, the baby head can be delivered. So if it is not delivered, the next step, you will ask one of the midwife, she will pressure, suprapubic pressure, she will do pressure on the back of the baby. So she will not do any direction, no, she should know where is the baby back. And when she know the baby back, she will do pressure. This pressure will reduce the fetal biacromial diameter, and this will lead to delivery of the baby shoulder. Remember, you are doing on the baby back. This will be reduce the base acromial diameter of the baby. And continuous pressure or rocking, no problem. I will do continuous pressure on the baby back or rocking movement, both no difference. So in both, still you can't deliver the baby. So either you will go for a maneuver, internal maneuver, or posterior arm delivery according to what you can do easily for the patient. What is the maneuver? It's easy. Look to the picture. It's wood screw. They will pressure on the posterior aspect of the posterior shoulder or the anterior. So in the posterior shoulder, you can pressure back or anterior. You need to rotate the baby. When you are rotating the baby will be rotated in a wider diameter, oblique diameter, so this can relieve the obstruction. If not working, you will go up to the anterior shoulder and you will do pressure on the posterior aspect of the anterior shoulder. Again, maneuver, internal maneuver, mute yourself. Okay. So the posterior, you will do either anterior or posterior pressure of the posterior shoulder. If not work, you need to pressure on the posterior aspect of the anterior shoulder. If not success, then you can go for delivery of the posterior, because when you are doing the pressure, this will lead to abduct of the shoulder and rotation in the oblique diameter, and the obstruction will be removed. Okay. All four position, if not all this one not working, all four like in the picture, and again you will start to do the procedure again to deliver the baby head. Success rate, it's about 80%, 83%. Be careful. This is not suitable for the slim woman. Will be suitable for the slim woman. It's not logic if you have obese patient, morbid obese patient, and you will tell her rotate. It will be difficult. Or if the patient, she has epidural, it will be also difficult. Delivery of the posterior arm, this is just need to be genital delivery of the posterior arm, because you can do fracture of the humerus of the baby, which can reach to 12%. You just sweep the baby arm in front of the chest and delivery. This is also will decrease the diameter of the shoulder stuck inside, and this is also can lead to delivery of the shoulder. If failed, you need to can fracture the clavicle, also can make the shoulder deliver easily, or the vaginal, you can return the baby head inside and you do cesarean section, or symphysotomy. It's difficult, but it's also recorded that symphysotomy can be done, just incision anteriorly in the symphysis pubis, and this ligament will be opened and will give a space for the baby to be delivered, but this is really need expertise operator. So if you look here, call for help. You see here in the start, he called experienced obstetrician with others. He start MRCOG, not working, add suprapubic, episiotomy for internal maneuver, either posterior delivery of the posterior arm or internal maneuver, failed. He will call the consultant here. After delivery of the posterior arm failed and internal maneuver, call the consultant, all four again, and repeat and check. Next.
Before asking it, I just wanted to know, in many questions, they give what you do after MRCOG and suprapubic pressure. We do internal.
Just to follow this. This is from Green Top guideline. So you will do MRCOG. Suprapubic, just follow the guideline. Don't be confused by any question. Just review the guideline. What is in the guideline, you will follow the guideline. Okay? So macrobar, suprapubic. After this, either delivery of the posterior arm or internal maneuver. If failed, you will inform the consultant, then all four. Same in the guide, you will follow the same in the chart. Okay? Next.
Infant of diabetic mothers have increased risk of shoulder dystocia compared with infants of the same birth weight born to non-diabetic. It's fourfold.
Fourfold? Okay, you can join the meeting. I think the meeting is open, correct? You can join the meeting, not locked, correct? There is fourfold increase of the risk of diabetic mother to have shoulder dystocia. So if you have one patient with diabetes, baby fetal weight more than 4.5 kilogram, so this patient she should consider cesarean section for her because this will decrease the risk. Any diabetes, gestational or pre-gestational. Okay. So the elective cesarean section, we finish this one. Elective cesarean section or vaginal delivery. Oh, so if the patient she has shoulder dystocia, so next time she will deliver cesarean or vaginal. This is just counsel again. We need to sit with the patient and discuss with her the risk of the next pregnancy. There will be tenfold increase of the shoulder dystocia, and if you want cesarean section, there will be also the risk of cesarean section, and discuss that this is operation and needs anesthesia, increase the risk of hemorrhage, internal organ injury. And in the end, no routine cesarean section, but there is several factors could make the cesarean section is the best choice, especially if there is severe neonatal and maternal injury, like her baby died during this delivery. So it will be a factors. It is not routinely to recommend cesarean section, but some factors should be taken in consideration. Next.
Regarding shoulder dystocia, which of the following statement is true? A large majority of infants with a birth weight more than 4.5 kg do not develop shoulder dystocia.
So A, the one true, yes, because we tell now majority of the baby more than 4.5, they will not develop shoulder dystocia. And we tell about 50% they can have shoulder dystocia if their baby weight less than 4 kilograms. After this, after shoulder dystocia, you need to document. You need to document in the patient file. What time the baby head deliver, what time the body deliver, what time call for help, what time they reach to the room, what is the maneuvers you used, each maneuver, how much time took, and which maneuver the baby shoulder deliver. So this is all should be documented, and even the baby condition, Apgar score after delivery, baby weight, pH, all this should be also documented in the patient file. So should be one of the one in the delivery room should be his work only documentation in the file. Baby after delivery need to be examined by neonatology clinician, debrief the patient, inform her about what happened situation again, document in her file incidence report to see if there is any defect in the management of the patient, especially if there is neonatal morbidity or maternity should have shoulder dystocia training at least annual. So this is the shoulder dystocia guideline, 2012 Green Top guideline. Fourth, management of third and fourth degree perineal tears. Okay. We can give a chance to others. Anyone more want to share? Thank you, Dr. Sumaya. You share how much question, Dr. Sumaya, because I didn't write. How many questions you share? Dr. Sumaya, you are here?
Yeah, maybe from 30
10 question from 40.
32 to 49.
40 to 42. Okay, so take more. Take 3 questions more. Okay, take 3 questions more. Okay, continue. Dr. Sumaya.
Overall incidence of obstetric anal sphincter injury in UK is A, 2.9%, 3.
Yes, the overall incidence is 3, 2.9, correct. In primary gravida 6, in multipara it will be 1.7. Don't forget 2.9 for overall, 6 for primary, and 1.7 for multipara 1. Okay, next.
Patient had vaginal delivery with 3rd degree perineal tear. Involved 50% of external anal sphincter, internal anal, and rectum intact. Which grade you will classify the tear? It's 3B.
3B, because less than 50, it will be A, correct? More than 50, it will be B. So it's 50. So I will put her with the higher one. Okay, you get the idea. Less than 50 A, more than 50 B. Where is the 50? So I will make it in the higher. So it will be in B. First degree perineal tear. This is injury to the perineal skin or vaginal mucosa. Second degree perineal tears. This is involve the perineal muscles. The tears will be in the perineal muscles, but still the anal sphincter intact. Third degree perineal tear. This is will be if less than 50% of external anal sphincter, it will be 3A. More than 50% of the external anal sphincter, it will be 3B. If include internal and external anal sphincter, it will be 3C. Fourth degree perineal tears, this will include anal rectal mucosa plus injury of the external and internal anal sphincter. This is very important classification. This is Sultan classification. And when you are doubt about the classification, just you will put the higher degree. There is buttonhole, it is not in the classification. Here the anal sphincter is intact, but just there is a tear in the rectal mucosa. And if you didn't recognize that there is, if you don't recognize during labor that there is a buttonhole tear, this can lead later to rectovaginal fistula. It should be recognized and sutured. Third and fourth degree perineal tears, it should be taken place in operating theater under general or regional analgesia with good light. If there is excessive bleeding, especially if the patient you are going to transfer her, so it's better to put vaginal bag because this will decrease the risk of the bleeding of the patient, decrease the blood loss, and shift the patient as soon as possible. It can be in the, if the degree, third degree perineal tears, it can be in the delivery room by senior obstetrician after discussion. Avoid 8 figures suture because this will lead to tissue ischemia. Rectal examination it's important to recognize if there is no any suture in the rectum, so it should be removed because if it is not removed, it can also lead to fistula. Broad spectrum antibiotic after delivery. In the patient with, we are not giving episiotomy routine, we are not giving antibiotic for episiotomy, but we are giving, if there is a broad spectrum antibiotic for obstetric anal sphincter, we will give her a laxative after delivery, but we are not giving her bulking agent as a routine. So we can give her only 1 laxative, not 2, but we will not giving her bulking agent as a routine because the aim, we want the stool to be soft, not loose. So we just wanted to give her something to make a soft stool until the stitch healing. So antibiotic, laxative, analgesia, and counsel her about what happened, physiotherapy, pelvic floor exercise, and we'll give her appointment after 6 to 12 weeks postpartum to check if she has any complaint. Maybe she has incontinence, and it's better to be seen by a clinician who is interested in obstetric anal sphincter injury. And we'll see if this patient, she will complain like incontinence. So this patient should be referred to colorectal surgeon because this patient could need for ultrasound, endoanal ultrasound scan. It's better to burning the surgical notes because this will avoid the migration. Okay, next. Dr. Sumaya, you can take this question also, then we will move to another one.
Yeah. Okay. Patient post-vaginal delivery with a 4th-degree perineal tear. Now we want to suture anorectal mucosa. It's 30 polygalactin.
Polygalactin, correct. So when you are going to suture the rectum, polygalactin 30, excellent. Okay, so the anorectal mucosa, internal anal sphincter, external anal sphincter. You should be careful in the exam how I will suture. And in the rectal mucosa, you will do either interrupted or continuous. So now you are delivering one patient, rectum opened. So how I will suture? I will suture interrupt. I can suture continuous, yes. So you can use continuous or interrupted. What is the type of the suture? The patient you will give to the, you will use polygalactin 30, easy. So we will move to the next. Now you want to suture the internal anal sphincter. So I can use interrupted, yes, not continuous, only interrupted here. So you take from the rectum, like the rectum interrupted, but can use mattress. So either interrupted or mattress. What I will use polygalactin, but here it will be 20. I can use BDS 30. The same suture will be used also for the external anal sphincter, so it's easy. The rectal mucosa, it's easy, one suture, polygalactin 30, very easy, 30. But I will make it 20 for the internal and external anal sphincter, and I will add BDS 30. Sometimes in the exam, they can give you use monofilament suture because already you have two. So he can give you this one, and you are confused in the exam. Both of you. So which one I will use? If he give you, I want to monofilament suture, so he want from you to use 3 PDS. If he tell you I want the braid suture, so he want from you to use polygalactin 20. So again, anorectal mucosa, interrupted suture or continuous, polygalactin 30. Internal anal sphincter, I will use interrupted or mattress. BDS 30, monofilament, polygalactin 20, braid suture. Same suture will be for the external anal sphincter, but here I will look external anal sphincter, it's complete or partial, full thickness tiered or partial. In partial, I will use only, because it's partial, so I will give him only one type of suture, end to end. But in full thickness, I can use two types, either end to end or overlap. So it's easy, just repeat. You can in the exam ask how you are going to suture, and you are confused, interrupted, continuous, I don't know. No, just repeat it in this way. It will be easy. Use needle, half circle, round body. Easy? Easy or no? Easy. It's easy. Okay, no problem. Use a figure of 8 we should avoid because this leads to ischemia, and we mentioned this point before. Rectal examination and suture should be removed if it is identified. We mentioned this one before. Documentation of the file regarding prophylactic episiotomy. It is not known if the prophylactic episiotomy will decrease the risk for the patient to have obstetric anal sphincter, but we just mentioned in the case if you are going to deliver a patient with nulliparous and you are going to apply forceps, so it's better to do episiotomy because this will decrease the risk for her to have obstetric anal sphincter injury. If the patient started to complaining incontinence, so you will refer her to the colorectal surgeon. He can do check for her if there is any endoanal ultrasound scan, if there is any abnormalities. So this patient, if she is complaining, symptomatic, and also if she has abnormal endoanal ultrasound, so this patient, she should have elective offer counsel about the option for elective cesarean section, because in the end, the patient, she will take decision for herself. Warm compression during the second stage of labor. This is also can reduce the risk of obstetric anal sphincter injury by evidence plus 1121. Hand-on technique. This is just you are putting your right hand on the perineum and the left hand on the baby head, and you are making the patient not pushing, mother not pushing while the head is crowning. And think about the episiotomy. They tell the hand-on technique also can decrease the risk of perineal tears. This is by evidence too. Perineal massage, this can be done in the antenatal care, especially in the last month or during the second stage of labor, as in the picture. This is also, they mentioned, it can be decrease the risk of perineal tears. Obstetric ileal and sphincter, evidence -1. Also, episiotomy, they tell just if it is needed, and when you are going to do episiotomy, it should be at 60 degrees and stretched perineum, and the protective of using episiotomy, it is conflicting, so it's not clear if it can decrease the risk of obstetric ileal and sphincter or not. Ridging maneuver, this is one of the types of the head support. This is you are putting support in the baby chin between the maternal anus and the coccyx of the mother, and this is not better than the standard care of hand-on technique. I think we mentioned this point is regarding the laxative antibiotic. Just this is repeated. Just I didn't delete this one, but just it's there. But we did this one already. Okay, next. Next.
I want to share.
Sorry. What is your name, doctor? What is your name? Hello?
Hello.
What is your name, doctor?
My name is Umar Hassan.
Yes, okay, doctor. Okay.
بسم الله الرحمن الرحيم. Patient post vaginal delivery within 4th degree perineal tear, want to complain, refer her to pulse, sound.
Pulse, correct. You are reading? Okay, no problem. You are just lucky. Okay, refer, I think that you are, okay, no problem. Refer her to pulse. Patient advice liaison service. This is for the patient to complain. If patient, you are lucky, okay? Remember this. Okay, so if the patient wants to complain, you will refer her to pulse. Okay.
Okay.
Next.
Women should be advised that of women are asymptomatic 12 months following delivery and external and sphincter repair. 60 to 80%.
Okay, so okay, correct. So 60 to 80% at 1 year, she will not have any symptoms. This means that 20 to 40% they will have symptoms. You can ask the question by the other way. So be careful. Excellent.
The risk of sustained a further 3rd to 4th degree tear after the subsequent delivery is 10%.
Recurrence, how much?
10%.
How much?
10.
No, recurrence will be 5 to 7%. If the patient asks you about the recurrence next pregnancy, it will be 5 to 7%.
5 to 7, okay.
Okay, we finished now the 3rd and 4th perineal tears. This is just a summary, 2015. Just this is a summary of this guideline. So we'll move now to the female genital mutilation. Very important. All these topics, very important topics. It can appear in the exam. Okay.
A lady came from abroad, admitted genital cutting as a child. On examination, total removal of the clitoris and labia minora, and excision of the labia majora. How to report this in her notes? Circumcision, FGM type 1, FGM type 2, FGM type 3, type 4, D, type 3.
Usually in the exam, once you see labia major, you will choose type 3. Be careful. I just put this one in the start because I know that you will choose 3. It's type 2. Be careful. Type 2 and 3, make it similar. But just in type 3, there will be narrowing. So labia major will be removed in type 2. So be careful, okay? But for type 3, let's go for this one first.
A lady come from abroad admitted genital cutting as a child. On examination, infibulation. How to report this in her note? This type 3.
Yes. He can give you infibulation or he can give you narrowing. He can give you also labia major and labia minor removed. Okay, but be careful. If he tell you labia minor and labia major, it will be type 2.
Type 2.
But he didn't give you there is narrowing. Be careful from this point. Okay. Because some thinking labia major, type 3. No, type 2. Okay. So this one will be type 3 infibulation. Correct answer. So type 1 partial, just make it easy for yourself. So clitoris or prepubis in the first one. 2, make it labia minor and major to make it easy for you. Type 3, make it like type 2, but here there is narrowing or infibulation. Make it easy. Don't complicate yourself. I know it's difficult. But make it simple. Type 3, if there is any piercing, incision, scraping, cauterization, pricking, cosmetic, sometimes I'm doing something, all this one will be type 4. AMQ.
Dr. Gada, please explain previous question. I didn't get that question, ma'am. Sorry to interrupt, ma'am.
No problem. Type 1 and type 3 and the one will make you confused in the exam, type 2 and type 3. Some thinking once they see labia major, oh, this is type 3. No, labia minor and labia major, when removed, this is type 2. When removed and there is narrowing, it will be type 3. Infibulation, will be type 3. Okay? Easy?
Ma'am, here it is not written like what type of, whether the os is closed or not. Nothing is written, ma'am. So how we can say it is 3?
Infibulation. This word only enough. This word. This word, doctor. You see this word? Infibulation. If you see only this word in the exam, this is type 3. Enough. Okay?
Okay, ma'am. Got it. Thank you so much, ma'am.
Okay. So just you see the infibulation, this means that this is type 3. Okay, next. So we mentioned the types. It's easy. Make it easy for yourself. AMQ. Okay?
Female genital mutilation, the most appropriate action. 57, woman with FGM has delivered smoothly, giving birth to a healthy baby girl. Using FNI risk assessment tool, the born baby was assessed as being at low risk.
Okay.
Inform police, inform child, safeguard, documenting social care information center database. C, I think. I'm not sure.
Which one? C, document to social
C,
health
yes.
with
yes.
C. You answer C. Okay.
Yes.
Next question.
Woman with FGM has delivered vaginally, giving birth to a healthy baby boy. There was a tear as at FGM scar tissue without bleeding. The woman requests to re-suture. E. Agree for woman for her request procedure.
Okay, E. Okay, E. Next.
Patient with FGM severely depressed due to irregular labor.
85 you choose E, agree with woman for her
Yes.
request procedure. Okay,
Yes.
next.
59, patient with FGM severely depressed due to her irregular labia with asymmetry in right side labia minora. Ask for labioplasty. Refuse. F.
Okay.
F.
Okay. So let's see the explanation, but careful. Female genital mutilation, this is usually will come in the exam. There is no any exam pass without question in the female genital mutilation. Be careful. A patient low risk, deliver baby girl, low risk. Just need here to document the patient. You will document the patient to social service. No need for child protection here or child because some they tell child safeguarding. No, the baby she is low risk, so you need to document her without anonymization. This means that you will record her name by Arabic اللي هو بنقول عليه نفي إثبات. So without anonymization mean with her name. So the first answer, you should document this patient to the social service. Patient, after you open the previous scar of hair circumcision, you can't do infibulation again. This is not allowed by UK. You can just, if there is any bleeding points, you can close. But otherwise, you will explain the patient that this is not allowed, and even you will explain for her before you are starting the procedure that when we are going to do de-infibulation, we can't do again resuture for it again. Just we can close the bleeding point to not be worried. Maybe she will bleed. You will tell her if there is any points of bleeding, we can do hemostasis. So here you will refuse the patient request because this is the law in UK. If you have one patient, she has problem because there is asymmetrical, already she has something in her organ. She tell you, I have asymmetry. In my right, she has already problem. Okay, she has already problem, so you can't refuse. You need to examine the patient, and if she need for a procedure, just you will agree with the patient because this is something affecting her. So if this one affecting her physically and also affecting her psychologically, you can agree for the patient as a cosmetic surgery. If she has already, if you examine her and there is nothing, okay, don't do. But if there is really something, because sometimes it can be very long labia, so you can't leave her. You will tell her not allowed. No, if it is cosmetically needed and this is affect the patient psychologically and physically, you will do surgery for her. We will about to finish, don't worry, maybe 15 minutes more. So this is the types. This is how we are going to do de-infibulation by local anesthesia. They are putting like an instrument here to protect the urethra. They will inject local anesthesia. It can be done as an outpatient clinic. And after this, carefully, they will open and they will open it separately like this. So if she tell you, no, doctor, I want to close, you will explain for her the law and you will tell her this is not accepted. This can be done as an outpatient. So re-infibulation, it's illegal in UK. You can't do for her again re-infibulation. This one you can do by scissor. It's better than scalp. You can inject the patient with local anesthesia, and we tell it can be done under local in the clinic. Except if the patient wants under anesthesia general, it can be done under anesthesia. What is this? What the same point is of we tell re-infibulation not allowed, but if there is any bleeding, we can close the bleeding points and just we will do repair as clinically indicated as any patient, but we will not close again. Okay, next.
Midwife inform you about woman in labor with FGM grade 3, cervix dilated 9 cm. She asked when defibrillation should be done. No need to do defibrillation done. when cervix fully dilated with crowning. With crowning.
What? With crowning. Yes, you will do with crowning. So when it can be a must, I can do in the start of the labor. Yes, you can do in the start of the labor if you can to do vaginal examination. So if vaginal examination not impossible and you can to do catheter easily for this patient, but the main point, if you can to do vaginal examination, so this patient you should do for her de-infibulation in the first stage. So you can do vaginal assessment for cervical, how you will assess the patient. Otherwise, you can do a crowning. So it will be under local anesthesia also. So offer the patient this is. So when I can offer the patient de-infibulation, if she come to my clinic, it can be before pregnancy. It can be before even the first sexual intercourse. It can be in the clinic. It can be under local anesthesia. It can be in the antenatal care under local anesthesia. It can be around 20 weeks. It can be during the first stage of labor, and we mentioned now if vaginal examination can't be, it can be with the baby delivery at crowning. If the patient not deliver normal, she tell you, okay, doctor, do for me, but for any reason, this patient you can't deliver her normal. You deliver her by cesarean section, so you can do after cesarean section. For any reason, you can't do after cesarean section. For any reason, you can arrange after delivery of the patient. Later on, she can have de-infibulation before future pregnancy. A patient with female genital mutilation for the first time should deliver in consultant-led unit, except if she is a low risk and she has already previous vaginal delivery, she don't have any problem. This patient can deliver in midwifery-led care unit. Okay, next. We are about to finish. Don't worry, we are about to finish. Dr. Hassan, where are you? Where are you?
Prima gravida, 6 weeks, pregnant, ask for termination of pregnancy. Midwife noticed that she has FGM type 3. Answer. If consider de-infibulation.
F. Okay. Next.
Patient with FGM with clitorectomy. Now request sting for reconstruction. She suffer from marked decreased libido. Refuse her request.
Okay. Refuse her request.
C.
62. C. Okay. Next.
Yes. 63. 17 years old patient gave birth to healthy boy. Midwife notes she has FGM done in her childhood. This repeated. Document without anonymization. H.
H.
Yes.
Why not should inform the police? She is less than 18 years. Why didn't inform the police? There is law if the patient less than for 18 years.
18.
Okay, I will tell you. You answer correct. No, you answer correct. Your answer correct. Okay, so we'll see the first one. You mentioned F, C,
yes.
H. Correct.
Yes. Yes.
Consider de-infibulation. Consider de-infibulation in the first one because you want to do D and C for her. Second one, the patient with the problem in her, she removed her. There is problem, decrease her libido. You will tell her that reconstruction of the clitoris will not improve her libido. So you will just counsel and refuse the request. In the third patient, even the patient girl and some even boy girl, any patient less than 18 years old, which confirmed from her history by examination or by history, you will notify to the police. But this will not be applied if the patient is pregnant. If the patient is pregnant and the low-risk patient, no need to inform no mandatory to inform the police or social services for her. So this will be applied for non-pregnant woman. If less than 18 years for the patient not pregnant, you will notify the police and social services. But for the patient pregnant woman already low risk, no need to inform the police. So your answer was correct.
Dr.
So
Gada, but the patient is less than 18 years. So even if the patient is pregnant, so we will not inform.
no, just I will. This is the next slide. Just wait 1 minute. Okay. So if the patient less than 18 years old confirmed from her history. Okay. If female genital mutilation is confirmed by history or just as they tell she has female genital mutilation by history, you will inform to the police within 1 month. This is the law. This is the law. If female genital mutilation is suspected, here you are suspect, but you are not confirmed. So you will refer her also still, refer her to social services or police. Urgency about the degree of risk. Non-pregnant woman, this is with female genital mutilation. Sorry, this is the pregnant woman, not non-pregnant woman. Just we will remove non, so you will not be confused. This will be the pregnant woman. So the pregnant woman with female genital mutilation, even she is less than 18 years old, not mandatory to report all of them to the police or the social services, just you need to document them. So if the patient is pregnant and is 18 years old, don't choose to inform the police, just document without anonymization. So with her name, you will document her with her name. Next.
A woman with FGM came for antenatal care at booking visit, offer screening for hepatitis B, HIV, and syphilis, hepatitis C, HIV, routine, hepatitis B, HIV, and syphilis. A.
So which one? A. So this is wrong answer. In the patient with female genital mutilation, you will add hepatitis C. You are correct regarding the routine investigation. Hepatitis C, it is not a routine investigation in antenatal care. But in case of female genital mutilation, hepatitis C will be added at booking visit. Also, all women with female genital mutilation should be referred for psychological assessment.
Okay.
Excuse me, Dr. Agada.
Yes.
Regarding the question number 63, I think.
Can we both
yes,
can make it in the end? Can make it in the end so we can finish first? Okay.
Yes. Yeah.
All questions I will answer after finish. Okay. So any patient with female genital mutilation with immediate access to emergency obstetric care should have intravenous access early and full blood count and group and safe, because they are more risky to have a postpartum hemorrhage. Okay, next. The prevalence within the countries, it will be various. Usually they will do female genital mutilation for the girls from infancy until 15 years. But when they are do surveys, they find about half of the countries they will do cut less than 5 years. Really, this is a crime. Less than 5 years, and they are doing female genital mutilation in almost half of these countries. The female genital mutilation will be done less than 5 years. Okay, next.
Which country has the highest prevalence in FGM? Somalia, Nigeria, Cameroon, Uganda. A.
Somalia. This is a correct answer. Somalia is the highest countries in female genital mutilation. This will be 98%. The lowest, Uganda.
Cameroon.
And the Cameroon similar to each other. Then Niger, not Nigeria. Niger will be the lowest.
Niger.
So Cameroon and Uganda, then Niger will be the lowest incidence of female genital mutilation. Next.
Regarding short-term complication of FGM, that's the most common immediate complication from FGM: hemorrhage, urine retention, genital swelling. Hemorrhage.
Hemorrhage. Yes, this is the most commonest immediate
complication.
Hemorrhage. Excellent, doctor. Excellent. Hemorrhage followed by urine retention, then genital swelling. 60, 50, 20. Make it like this: 60, 50, 25. 60, 50, 25. So this is the commonest will be hemorrhage. Okay. Long-term complication: genital scarring, urinary tract infection, dyspareunia, apronia, impaired sexual function, psychological complication, menstrual difficulties. She is more risky also to have bacterial vaginosis and type 2 herpes simplex. Bacterial vaginosis and herpes simplex type 2 plus HIV, hepatitis B and C. Female genital cosmetic surgery. Patient, she will come asking for cosmetic surgery. Any patient come to your clinic less than 18 years asking for female genital cosmetic surgery, you just will tell her that still the vulva not fully developed. Just you need to come back after 18 years and we will check the situation. Because maybe the change, it will be variable. She will tell you it's different from others. Just you will tell her it will be variable. You can give her box, patient information leaflet, and she can read more. But you will not do female genital cosmetic surgery under 18 years. But after 18 years, if it is necessary, be careful. Be careful. Should be necessary. So it will be considered as a female genital mutilation and you will be under law. So should be necessary, so you can do if it is affected the patient psychologically or mentally. If the patient not speaking English, any patient in the exam, he give you, she can't speak English, this patient, you can't use any one of the family members as interpreter. Even the staff, nurses, doctors should be official interpreter, except in one reason only. There is immediate risk for the patient life. There will be delay. Patient will die. In this condition only you can take from the family because there is something immediate need immediate. Otherwise, this patient should have interpreter to because this will be a communication barrier between the patient and the doctor. Health professional should be aware regarding how to document difference between documentation and reporting. When you are going to document only the patient, when you are going to report the patient, you will reassure the patient that we need to document you. This will be without anonymization. We will put your name. This will be to the health information centers. What is the name of health? HCCIC, Health Social Services, I think, Information Center, as I remember. This will be just we are documenting your name there. Why? Because we want to avoid duplication of the record. We'll tell her because maybe she will come today to the clinic, she will go another clinic, so I need maybe there will be double duplication of the record. But we will reassure her that any publication of the data, when publish the data, your name will not be there. So there will be confidentiality for the patient. We need to document for the patient what is the age the female genital mutilation done, at which age, where it is in the UK or outside UK, and if there is any history of defibrillation or not. It's important to document in the baby. This is the red book. This is for the baby health. This is like اللي هي شهادة التطعيمات بنسميها شهادة التطعيمات والvaccination بتاعت البيبي. So this will be the red book. This red book, if the patient should deliver baby girl, if the baby whatever she'll deliver baby boy or girl, just you will need to document that this is baby of a patient with female genital mutilation. But if the patient deliver baby girl, you need to inform designated child protection midwife, who will inform the GP and the health visitor, so they will be careful that this baby girl, her mother, she has female genital mutilation because maybe she is at high risk to have female genital mutilation. Yes, health and social care information centers. Okay, thank you, doctor. Okay. So the last point, female genital mutilation, this is a severe form of violence against women and girls. Female genital mutilation, this is a crime against humanity. This was the last today. I know it's much, I think much information. I don't know if you like this. I think I'm also fast and this is maybe not, you give the answer was documented without anonymization. Yes, yes, we will document here without anonymization. Without anonymization means with her name. With her name. Some thinking without this means that you will not put her name. No, without anonymization means that you will put her name. Sorry, the system today faster, but you need just to repeat. If you repeat it again 2 times, it will be easy. It will be easy. Okay. You can answer the question you send in the scan, please. This is record. Please, we don't want to talk about this point now. Okay. Dr. Adila, what is your question before close the session? Because I think all of you tired now. Okay,
About
Dr. Adila, what is
question, about question number 63 about clitoridectomy.
Yes, 63. Okay. What is the problem in the question?
The answer, I think it was refused. No, not this one. Yeah, the 62. 62. Okay. The answer was refuse her request, but why not G, refer for sexual assessment?
The first one will be refuse her sexual assessment, refuse, or the second one will be refer. Which one will be the first?
Refuse, yeah.
I saw this guy in a movie. It's a step. It's a step. I can refer her, but first one, she come now. She want to request, so I need to answer her. Correct? I need to answer her. What is the answer? It's through counseling. So reconstruction of the clitoris, this is will not improve her condition. First, I will counsel her. After this, I can give her other options, but I can't jump. I will tell her, go to this one. So what she understands? She don't understand anything. She don't understand. She will come back for you and you will do for her or no. You should first start the counsel and answer her request. She come for reconstruction. So the answer, we should tell her that the reconstruction will not help her. This is the first step.
Okay, thank you. Okay.
If we get any other questions, just post in the group because I am really tired. My voice already also, I think I need to go refresh myself. So any more questions, just post in the group. I'm really sorry if today's session is faster, but you know, this is 5 guidelines. 5 guidelines, it's much time. You can take only 1 guideline, you can take 1 week reading. But this is just the summary, the more important summary. Don't write this word again in the chat, please. Please. Okay, we will discuss in the group, okay? We will discuss in the group. Thank you for all of you. And recall the group and the Facebook group, Ghada Badran Facebook group, and recall the group in Telegram. Thank you for all of you and see you soon, inshallah. Goodbye.
جزاك الله خيرا دكتورة غادة.
Thank you very much.
Hello, hello, Dr. Gada.
Thank
Hello?
you. Thank you.
Thank you.
Hello?
Thank you.
Thank you. Thank you, Dr. Gada.
Hello?
Thank you, Dr. Gada.
Dependent variable, okay? Dependent variable is whether the person is diabetic.